Acute myocardial infarction after laboratory confirmed influenza infection. Definition. Acute myocardial infarction is an event of myocardial necrosis caused by an unstable ischemic syndrome. This can be triggered by acute respiratory infections. Previous studies have suggested an association between influenza and acute myocardial infarction, but those studies use non-specific measures of influenza infection.
Myocardial infarction, commonly referred to as heart attack, is the sudden death of part of the heart muscle due to loss of blood flow. This occurs when one of the coronary arteries, the arteries that supply blood to the heart, is blocked. The blockage is commonly due to atherosclerosis, cholesterol plaques or fat deposits on the wall of blood vessels. As the plaque builds up, the vessel becomes narrow, restricting blood flow. Under stress, the plaque may rupture. This triggers formation of blood clot on top of the plaque, leading to complete blockage of blood flow. When this happens in the coronary artery, the downstream patch of the myocardium dies from lack of oxygen. Weakened heart muscle may disrupt electrical activity of the heart and subsequently cause cardiac arrest. Coronary angioplasty is a non-surgical procedure used to open narrowed or blocked coronary arteries. It can also be performed as an emergency treatment for myocardial infarction. The first part of the procedure is to localize the site of blockage. This part is called cardiac catheterization. A guiding catheter is inserted through the femoral artery at the groin and threaded all the way to the aorta. The tip of the catheter is placed at the beginning of the coronary artery to be investigated. A radio-opaque dye is injected through the catheter into the coronary artery. This enables real-time visualization of the artery using X-ray imaging. A narrowed part of an artery would appear as a bottleneck on an X-ray image. After the location of narrowed artery is identified, angioplasty can begin. A guide wire with a deflated balloon is inserted and pushed to the location of blockage. The balloon is inflated to crush the plaque. At the end of the procedure, the balloon is again deflated and removed together with all catheters and guide wire. In some cases, a stent is inserted together with the balloon, inflated, and left in place of the plaque to keep the artery open permanently.
Applications in medicine. To evaluate the association between laboratory-confirmed influenza infection and hospitalization for acute myocardial infarction, they use self-controlled case series design. Various high-specificity laboratory methods to confirm influenza infection in respiratory specimens and ascertain hospitalization for acute myocardial infarction from administrative data.
This patient is experiencing an acute myocardial infarction due to a ruptured plaque creating thrombosis of the proximal segment of the left anterior descending artery. Our current approach for patients with ST segment elevation myocardial infarction is immediate cardiac catheterization and percutaneous intervention. Balloon dilatation is first performed. Dissolution of the thrombus results in distal microembolization. Occlusion of the distal microvascular circulation increases myocardial injury, which may be reflected in further increased myocardial enzyme levels and additional myocardial damage. Following balloon dilatation, a long atherothrombotic lesion remains. Stent placement compresses the residual clot under the stent struts and causes a cheese grater effect. This results in an additional thrombotic embolization. Due to the apparent long length of the lesion, a second stent is placed. Placement of this stent also causes some distal embolization. Although the angiographic result is quite acceptable, a significant amount of residual thrombus persists, both at the stent edges and adherent to its struts. The poor distal microcirculatory flow, as assessed angiographically by myocardial blush, strongly correlates with a poor clinical outcome. Patients with ST segment elevation myocardial infarction may benefit from thrombectomy at the site of occlusion before balloon dilatation and stent implantation, thereby preventing embolization and distal myocardial injury. The same patient could be treated with angiojet thrombectomy prior to stenting. The angiojet catheter is shown here removing the bulk of the thrombus. A second pass removes more thrombus. The angiojet catheter is passed several times until the operator is comfortable that all angiographically apparent thrombus has been removed. This reveals a short, moderately stenotic plaque, which is treated with a single stent without the need for predilatation. There is minimal, if any, residual thrombus present at the stent site. Angiography following thrombectomy and stenting shows an excellent result. In summary, percutaneous intervention in the setting of acute myocardial infarction due to coronary thrombosis is frequently associated with distal embolization and additional myocardial injury. Angiojet thrombectomy reduces the overall thrombotic burden, reduces distal embolization and its associated myocardial injury. In patients undergoing placement of a drug-eluting stent, treatment of coronary thrombus plays a particularly important role. Although proven effective in reducing restenosis, the safety and effectiveness of drug-eluting stents has not been established in patients in whom there is unresolved thrombus at the treatment site. Thrombus compressed under the stent struts may prevent optimal apposition and contact between the stent struts and the vessel wall. In this situation, the true vessel size may be severely underestimated, and incomplete strut apposition may occur. Successful removal of thrombus using angiojet thrombectomy may permit more appropriate stent selection, ensuring complete stent apposition and contact between the stent struts and the vessel wall.
Several studies have demonstrated an association between influenza infection and acute cardiovascular events. But most previous studies were limited by inaccurate methods of diagnosing influenza, and the few studies that ascertained infection by laboratory testing were underpowered and had inconsistent findings. Canadian investigators have now carried out a self-controlled case series study with laboratory-confirmed influenza to assess its association with acute myocardial infarction. Using a linked database of respiratory virus testing from 19 laboratories and a separate database of all admissions to acute care hospitals, the authors identified 332 Ontario residents who were at least 35 years of age and had been hospitalized for acute myocardial infarction within 1 year of a positive influenza laboratory test. They then compared the incidence of hospitalizations for acute myocardial infarction during the risk interval, days 1 to 7 after a positive influenza test, with that during the control interval, the 52 weeks before the positive test and the 51 weeks after the risk interval. Of 364 unique hospitalizations for acute myocardial infarction, 344 occurred during the control interval, a rate of 3.3 admissions per week, and 20 occurred during the risk period, a rate of 20 admissions per week, 6 times as high. In contrast, similar increases were not observed during days 8 to 14 and days 15 to 28 after an index influenza case. The increased incidence was robust to sensitivity adjustments, such as using multiple different risk and control intervals. The authors also found a smaller but significantly increased incidence of acute myocardial infarction admissions after positive tests for respiratory syncytial and other viruses, and after respiratory illnesses without an identified virus. The authors conclude that there is a significant association between respiratory infections, especially influenza, and acute myocardial infarction. Full trial results are available at nejm.org.
Issues applying in Ecuador. Although there are no statistics real in the Ecuador, it is worth mentioning that in the United States happen 1 million strokes per year. The incidence of acute myocardial infarction may be close to 40,000 people a year, which means that every 12 minutes an Ecuadorian suffers a heart attack. Conclusion. In this study, in which they use specific definitions of the exposure and outcome in a self-controlled design, they found a significant association between acute respiratory infections, particularly influenza, and acute myocardial infarction.
People struck down by flu are 6 times more likely to suffer a heart attack within a week of their diagnosis, a new study warns. Researchers say their findings reinforce the need for people deemed at high risk of suffering a heart attack to get a flu shot. The team at Public Health Ontario in Canada discovered a significant association between acute respiratory infections, particularly influenza, and acute myocardial infarction, the medical name for a heart attack. The researchers also found an elevated risk of heart attack from other respiratory viruses, but none as high as flu. Experts warn the findings, published today in the New England Journal of Medicine, suggest the risk may be higher for older adults, patients with influenza B infections, and patients experiencing their first heart attack. Study lead author Dr. Jeff Kwong said, "Our findings are important because an association between influenza and acute myocardial infarction reinforces the importance of vaccination." Our findings, combined with previous evidence that influenza vaccination reduces cardiovascular events and mortality, support international guidelines that advocate for influenza immunization in those at high risk of a heart attack. The researchers looked at nearly 20,000 Ontario adult cases of laboratory-confirmed influenza infection from 2009 to 2014, and identified 332 patients who were hospitalized for a heart attack within 1 year of a lab-confirmed flu diagnosis. Dr. Kwong added, people at risk of heart disease should take precautions to prevent respiratory infections, and especially influenza, through measures including vaccinations and hand washing. The researchers said that patients should not delay medical evaluation for heart symptoms, particularly within the first week of an acute respiratory infection. The finding comes amid one of the deadliest flu seasons in years. Despite hopes the flu would ease off this week, as did the similarly deadly 2014-15 season, data released last week reveal the opposite. The rate of people with influenza-like illness this season has now eclipsed every other year since 2010. Another 10 children have died this week, another 14,401 people got sick, and hospitalizations have climbed up from last week's 22.7 per 100,000 to 31.5. The proportion of elderly deaths from flu, compared to other causes, is also above average at 8.2%.